here from Baltimore, and so it is, a distinct pleasure for me, an honor to get to introduce you to our hometown health commissioner. Dr. Dzirasa, some people call her Dr. D. It's not as scary sounding a name, but the D and the Z go together, and it makes sense to say it enough times, but it's scary. Was appointed by the mayor of Baltimore City, the health commissioner for Baltimore City in 2019. And she stepped into that role, I'm sure, hoping that she'd have a little time, to get situated and learn the different agencies, the hundreds of staff that she is now managing, to understand more about the community and the community needs. But instead, an infectious disease outbreak happened. And not the one you're thinking. It was measles in 2019, right? So in 2019, we had here in Baltimore a measles outbreak. And so Dr. Dzirasa literally hit the ground running. She and her staff had to contain the spread, to educate the relevant community, and to break the barriers of people who were not vaccinated and were rejecting vaccines, right? So all of that work that she did in 2019, little did she know, little did the staff know, it was foreshadowing what they would so ably take on in 2020 and beyond with the COVID pandemic. So who knew? But it was a great trial run to get it right in Baltimore City. Dr. Dzirasa came into this position with an array of experiences coming from a non-NGO in Baltimore City, Fearless Solutions, which is I had to look this one up because I didn't know what it was. It's a digital services firm where she did their health IT. She managed their health IT portfolio, which, of course, many of you in the room know how important information technology in the health sector is. Was with Fearless for some time before she became health minister. Before that, doing her pediatric training at Johns Hopkins Hospital, up the street, down the street, whatever, I'm not good at that sort of thing. And then served as medical director for school-based health and quality at Baltimore Medical Systems from 2013 to 2016. In addition to having her medical degree from Meharry Medical College, graduating summa cum laude, impressive. She before that was a retriever, which if you're local, you know that she graduated from the University of Maryland, Baltimore County, one of the first 15 seats to knock off a 1 seat in a NCAA partner. There you go. Those retrievers, that's what we're going to be known for forever. But we've also produced an incredible health commissioner for Baltimore City. So her specialty areas, obesity management and prevention, trauma-informed care in children and adolescents, and expanded use of technology to improve health outcomes. I spoke with her a little bit earlier about what the priorities are moving forward for the city, and she spoke about the child fatality review work that they're doing and reducing the trauma in communities of losing everything for many measures, for many needs. And so, happy that folks as good as Dr. G are working in that area. I want to give you then one last story of why I love that she's coming to this public health law conference, just a public health conference. When I first met Dr. Dzirasa with Dr. Sharfstein, Josh Sharfstein, we were there to talk about a complicated data and privacy question, how the city could gain access to certain data to help with some asthma issues that were going on in the city, and just like intricate legal questions. And frankly, the city solicitor's office is great for Baltimore City, but this was a very complicated question that needed a little bit more. And the one thing that Dr. Sharfstein and I left Dr. Dzirasa's office with was, hey, it'd be really great if you got yourself your own attorney. This would really help you with these understanding to some of the complicated public health law and policy things you're going to work on when you're here in the city. And I'm not saying she did it because we told her to do it, but she did it. So what that tells us is that she does value the input of an attorney, the input of us, the network, and the input of kind of the legal practice in being an integral part in public health. So I thank her both for all of the work that she does for Baltimore City, but also for recognizing the role that lawyers can play in this space. So on that, Dr. Dzirasa.
Good afternoon, everybody. Well, thank you, Kathy, so much for that gracious introduction. I do think that lawyers are very important as a position. 3 of my deputy commissioners are lawyers by training. training as well. My chief health policy officer who's here today is also a lawyer. So very, again, very supportive of the work that you all do, because it's not something I can do. I try to stay in my lane, and that has served me well today. So also want to just thank the Network for Public Health Law for this opportunity to speak with you all today. If you're like me, you're getting accustomed and getting adjusted to being in person again. So this is a good kind of warm-up exercise as we all get back to it. But again, I am so honored to be here today. It really is my distinct pleasure to welcome you all to the 2022 Public Health Law Summit in the one and only term, my city for the past 12 years. While my sincerest hope is that you all enjoy Baltimore to the fullest, you eat great crab cakes, you see things that inspire, not the Orioles, but maybe other things that inspire you. I also hope that you talk with your colleagues, that you get to know one another, because it's in those conversations that you begin down that path towards lasting change. So because while I know that these sessions today are going to be, phenomenal, I was looking at the brochure and I saw things from the epidemiology of public health law, and protecting rights within public health. All of these things are just amazing topics. And I know that they're going to provide you all with tools that you can take back with you when you go to your respective workplaces. But again, I want to go back to having those discussions with your colleagues, exchanging those ideas, talking about those best practices, because I believe that that's where transformation policy begins. I know if you're like me, you're intimately familiar with the shifting personal and professional landscapes that we find ourselves in during this unprecedented time. We all saw public health take center stage in 2020, and we continue to see public health law applied in such a dynamic way. So whether it's the state or local government declaring that public health emergency, or the rise in litigation that we're all seeing as it relates to restricted rights during the pandemic, the public health law arena is further evolving into a proactive mechanism for change, one that can shape health ecosystems to match the needs of the populations we all serve. And while, again, all of those forces I mentioned are so critical as you all travel along your respective career paths, I think that the underlying theme and guiding ideology of this conference is critical: strengthening protections for community health and advancing health and racial equity. The COVID-19 pandemic has brought public health and subsequently the long-standing challenges in achieving health equity to the forefront. It is up to all of us to now seize this opportunity to reaffirm racism as a public health crisis and to provide solutions focused on addressing health inequities. The disparities in COVID-19 disease outcomes illuminate what I'm guessing most people in this room already knew. Our system is broken, but it's not by chance. It is by design, and it's going to take significant investments and policy changes at both the macro and micro levels to fix it. In the past few years, COVID-19 disease disparities coupled with the killing of unarmed Black and Brown people by law enforcement have helped to generate a more global conversation around long-standing racism in our built and social environments. However, just having a conversation about structural racism is only the first step to establishing meaningful policy change. Creating an anti-racist agenda requires a multi-pronged approach. It is paramount that we understand the foundations in which institutions have been built if we want to make a difference. This understanding allows us to better identify the root causes of health inequities so that we can create policies that are both impactful and sustainable. So what does that look like in practice? Let's first start with some historical context. We're here in Baltimore, the home of redlining. Redlining, for those that don't know, was a discriminatory practice of denying mortgages to residents in certain areas based on their race or ethnicity, and it still impacts health outcomes today. Even though the practice of redlining in Baltimore was most prominent in the 30s and 40s, it continues to contribute to hyper-segregated neighborhoods here in the city almost 90 years later. And we still see today where those neighborhoods have equitable access to transportation and healthy food choices. Those same neighborhoods are home to chronically underfunded public schools, and the residents living in those same communities lack equitable access to primary care. Data shows a correlation between historically redlined neighborhoods and current incidents rates of asthma, cancer, tuberculosis, lead poisoning, smoking, and a host of chronic diseases. In the context of the COVID-19 pandemic, Black and brown residents are more likely to live in areas that are further from grocery stores and medical facilities, making it more difficult to receive necessary care if infected, or to stock up on supplies that allow one to safely isolate. In addition, more African Americans and Latinx individuals work in essential service industries, which by nature places them at increased risk for contracting COVID. Black city residents also have higher rates of poverty and unemployment, as well as lower rates of home ownership, and are twice as likely as their white counterparts to be uninsured. So unfortunately, it was not surprising that those same disparities manifested in COVID-19 case rates from the very onset of the pandemic, and they continue even now. So now that we have some history and background, what is today's data telling us, and how do we let that data guide our program? Throughout the pandemic, like every other city, Baltimore City saw disparities in case rates, hospitalizations, and deaths. In Baltimore, as of December 2021, Black city residents accounted for 73% of COVID-19 related deaths, yet only comprised 63% of the population. Additionally, Latinx residents accounted for 9% of cases, yet they only make up about 5% of our population. Early on as a city, we displayed and utilized case data to determine where to allocate our limited testing resources. Our first stationary testing site was established in April 2020 in the 21215 zip code. At the time, 21215, whose population is about 82% African American, had been identified as the first hotspot in the city, having some of the highest case rates that we saw. Shortly thereafter, 21224 was identified as the next hotspot in the city. Anecdotally, at the same time, we were also hearing from our hospital colleagues that work in the zip code that they were seeing a large influx of Latinx community members coming into the local hospital. We would subsequently establish one of our first mobile testing sites in 21224 alongside hospital and community-based partners. Not only did we provide those testing resources, we were also intentional about working with community partners to provide the wraparound support services needed in this community so that community members could safely isolate or quarantine while still providing for their families. So while knowing the history and understanding the data are important, it is critical that programmatic interventions and policy recommendations are also community informed. Having the data while also working alongside the community to problem solve has allowed us as a department to customize and fine-tune our approach throughout the pandemic response. A prime example of this was the establishment of our Value Community Ambassadors Program. In partnership with Morgan State University, a historically Black college university, Johns Hopkins International Vaccine Access Center, and the Maryland Institute College of Art, the health department established peer value community ambassadors. These ambassadors focus their outreach on 10 subpopulations in our city that have either noted a higher disease burden or who have historically had less access to care. We hire community members who already lived or work in the communities most impacted by COVID-19. A few examples of those value communities include young men of color, our Latinx community, pregnant and lactating individuals, older adults, and adults living with disabilities. We wanted to reduce vaccine hesitancy by creating demand for vaccine via these trusted messengers. Our ambassadors host community events, they call and text residents, they canvass and promote vaccination clinics by having one-on-one conversations. To date, our ambassadors have engaged with over 127,000 residents in Baltimore City. Another effort to provide support to our most vulnerable residents came through establishment of a triage resident isolation center in May 2020. The health department, the mayor's office, the University of Maryland Medical System, and the Lord Baltimore Hotel established this tri-site with the goal of housing city residents with known or suspected COVID who are unable to isolate or quarantine due to their living situation. The integrated care model offered by the tri-site also provides wraparound support services for those residents. This includes connection to substance use disorder treatments or helping them to obtain a valid ID. In September of 2020, we expanded the tri-site's work to include support of high-risk residents that were at greater risk because of underlying comorbidities on a more long-term basis. So not just isolation and quarantine, but providing them with some temporary housing and wraparound case management. Since the TriSet has opened its doors now almost 2 years ago, more than 3,300 individuals have been supported to safely isolate or quarantine, and over 170 residents have been served through our Haven program. Another key health department initiative focused on addressing health inequities involved creation of the Baltimore Health Corps program in June 2020. This program was established alongside other city agencies through a public-private partnership with local and national philanthropy. At its core, it's a workforce development program with the goal of providing training on top of helping individuals become gainfully employed. In addition, the other major goal of the program was to bolster our ability as a health department to reach residents most impacted by COVID. Through this program, we hired almost 250 city residents who were either unemployed or underemployed as a result of the pandemic. The Baltimore Health Corps program also allowed us as a department to rapidly expand our contact tracing efforts and increase our ability to support city residents through care coordination while also providing much needed public health education and outreach. So knowing the history, using the data, combined with a multi-sectoral community engaged approach, has allowed us to address some of the environmental and social barriers to accessing care and resources. And while I've highlighted some of our downstream initiatives, as we look forward to policy changes, it's imperative that we also focus upstream. So we must recognize the contribution of structural racism to the disparities seen in COVID-19 and so many other disease states. We must recognize that any solution or policy must be data-driven and community-informed. While we still have the nation's attention during this public health emergency, now is the time to translate what we know into policies focused on addressing the social determinants of health. Now is the time to highlight programs that work, while also championing policies that directly address the structural inequities that created a need for those programs in the first place. We must advocate for affordable housing, increase green spaces in our urban areas, parity in funding in our local public schools, equitable access to safe transit, enhanced job training, improved access to culturally competent primary care, access to grocery stores, and a living wage that supports upward mobility. If history's taught us anything, it's that we can't do this work alone. We all have different roles to play. For some of us, that role is in researching, publishing, and writing about these inequities. For others, that work is done in the form of advocacy at the state or federal level, alongside other respected leaders and legislators. And for some, that work is done by providing education and training to influencers and decision makers on what a health and all policy approach looks like. That's why a conference like this is so important. Joining forces and voices across multiple entities and industries will be critical as we advocate for systemic change. Over the next several days of this conference, I implore you all to take advantage of everything that is offered and spend time evaluating your scope of impact. We all have the power to create and practice solutions that are equity focused. Please be intentional about getting to know one another so that you can leverage each other's expertise and unique set of experiences. Take what you learn back to your colleagues in your respective communities for a better, more equitable future of health. Thank you.